This lecture will cover the pharmacotherapy of select gastrointestinal disorders. I will not spend extensive time reviewing the pathophysiology of these disease states. By the end of listening to this lecture, I hope that you have a good understanding for the pharmacology of agents that are discussed that are used to treat constipation, diarrhea, GERD, peptic ulcer disease, and irritable bowel syndrome. We'll start with constipation and diarrhea. Constipation can vary from patient to patient, but the objective definition is that patients have a bowel movement less than 3 times per week. There can be multiple causes for this. Maybe anatomic, there may be specific GI disturbances, there may be neurologic issues that may affect muscle tone, there may be metabolic changes or psychologic changes that all contribute to constipation. From a pharmacy perspective, we need to make sure that we're screening each patient's medication profile for any offenders. I would spend specific time looking at medications that are new or newly have dose increases when assessing a patient who's newly developed constipation. Some of these high offenders may include opiates, anticholinergic medications, or diuretics. There are 6 different types of laxatives: bulking agents, stool softeners, stimulant agents, saline laxatives, osmolar agents, and enemas. In addition to the pharmacotherapy used for constipation, patients who develop constipation should also be counseled on non-pharmacologic therapy, things like exercise, increasing fluid and fiber intake. These things are not good at acutely treating the constipation, however, they should be used to prevent constipation from developing. We'll start with the bulking agents. These agents are indicated for the treatment of chronic atonic or spastic constipation, constipation associated with rectal disorders, and irritable bowel syndrome. These are all fiber derivatives. These most resemble the normal physiology of the GI tract. They absorb water, swell up, and stimulate peristaltic activity. These are identical to the action that dietary fiber has in our body. These include things like psyllium, methylcellulose, and even high-fiber foods like bran cereal. These are not systemically absorbed. They are safe and they can be used on a daily basis. They do take a while to take full effect. The onset is anywhere between 12 and 24 hours. However, some patients may take up to 3 to 4 days to see that full effect. They should not be used in patients who are obstructed or impacted. We need to also ensure that patients are taking these with adequate fluids. If not, they can lead to an obstruction because they're absorbing that fluid and they need enough fluid in order to function appropriately. They should be taken at least with 8 ounces of water, and patients should be counseled to increase their fluids throughout the day as well. Because of that, these are not the best agents in patients who are fluid restricted, so those with heart failure or renal disease. We also need to use them cautiously in patients who are older because they may have inadequate fluid intake as well. The next group we'll talk about is stool softeners. Stool softeners are indicated for patients who should avoid straining during defecation or have a history of hard stools. Patients who should avoid straining are those who may be post-myocardial infarction. They can help relieve painful elimination of a bowel movement, so those patients who may have a history of hemorrhoids. This group of drugs is also known as surfactants. They act by lowering surface tension. Essentially, they're basically soaps. They allow the fecal mass to absorb intestinal fluids. The main medication in this class is docusate. Again, these agents assume adequate hydration. They shouldn't be used in a patient who already has soft stools. They can take about 12 to 24 hours to take effect. Again, patients may not see that full effect for about 2 to 5 days. So you're not going to get a really quick acute onset with these. These are safe for use in older adults. There is not a lot of efficacy to support their use. You may often see them used in combination with a stimulant laxative because of this varying efficacy. Stimulant laxatives are indicated for the short-term treatment of constipation or to evacuate the colon as part of a bowel prep regimen. They are often used in combination with stool softeners. There are several drugs in this class, the first of which that we'll discuss is Senna. Senna will stimulate colonic intramural nerve plexus to produce peristalsis. Senna works relatively quickly. It has an onset of about 6 to 24 hours, and it's administered as an oral tablet. Patients who are on chronic opioid therapy should be on a stimulant laxative in combination with a stool softener. So either Senna or the next stimulant that we may talk about, which is bisacodyl. In general, this class can have some adverse effects, mainly GI in nature. Patients may experience cramping or abdominal pain because of how these drugs are working. Bisacodyl is the other agent in this class. Bisacodyl stimulates nerves in the intestinal mucosa, which will increase intestinal chloride secretion. The overall result of that is net fluid accumulation. This is available orally and as a rectal suppository. Orally, it has an onset of about 6 to 10 hours. It is recommended that patients take this product at bedtime. Rectally, the onset is much quicker and it will work in about 15 to 60 minutes. The next class that we'll talk about are saline laxatives. These include medications that are magnesium-based, so things like milk of mag, magnesium citrate, and also sodium phosphate. Magnesium citrate and sodium phosphate are typically reserved for bowel preps only. These work because of their osmotic effect. They're drawing water into the lumen of the small intestine and colon and promoting peristalsis. All of these agents in this class do assume that the patient is well hydrated. The onset for milk of mag is about 4 hours. For magnesium citrate and sodium phosphate, these will work within about 1 hour. Because of this, oral meds should be avoided within the hour before administration. These can cause electrolyte abnormalities and dehydration as well as cramping. Because of the potential for electrolyte abnormalities due to the administration of both magnesium and phosphate, these should be used extremely cautiously in patients who have renal failure. Both magnesium and phosphate can accumulate in these patients, especially with repeated doses. Of the agents in this class, milk of mag is the safest. The next group that we'll talk about are the hyperosmolar. These include things like lactulose, glycerin, polyethylene glycol, and sorbitol. The osmotic effect of these agents in the colon will draw fluid into the intestinal lumen, distend the bowel, and promote peristalsis. These are often used as a bowel prep. They can be somewhat harsh in that patients may experience stomach cramping or severe stools. They have a rapid onset within 1 to 2 hours. Very similar to the use of magnesium citrate and phosphate laxatives. For patients who are receiving bowel preparations with polyethylene glycol, it's recommended that they avoid oral medications within an hour of that administration. Miralax, or a lower dose of polyethylene glycol, is also in this class of drugs. Because it's a lower dose, it is safe for everyday use short term. Long-term effects, meaning over decades, have not been well studied, but it is, and short-term used at a lower dose, it is a safer, more tolerated formulation of this class of laxative. The next group that we'll talk about are enemas. Mineral oil, sodium phosphate, and tap water can all be administered via the enema route. Basically, these medications will create a barrier between feces and the colon wall and prevent colonic reabsorption of fecal fluid. To a lesser extent, they do have a lubricant effect that will ease passage of feces through the intestine. A fleet enema is a sodium phosphate enema that should be avoided in patients who have renal failure because of a high phosphorus load. The newest agent that's used for constipation is methyl naltrexone, brand name of Relistor. This is available as a tablet or subcutaneous injection and is indicated for opioid-induced constipation in adults with non-cancer pain or patients who have advanced illness, which is defined as those who are under palliative care and do not respond to other laxative. This agent is a peripheral acting opioid receptor antagonist. It can block the GI effects of opioids without negating their analgesic effects because it does not cross the blood-brain barrier. However, in theory, in patients who have disruption to their blood-brain barrier, opioid withdrawal can occur, and this is something that should be monitored for. Adverse effects for this product are mostly gastrointestinal in nature. Severe adverse effects include GI perforation, severe persistent diarrhea, and opioid withdrawal. However, abdominal pain is the most common side effect reported, and that does occur in about 14% of patients. The next group we'll talk about are the antidiarrheals. The best way to control diarrhea is to determine the source and to treat the source of that diarrhea. If symptomatic agents are needed, you can use an antidiarrheal product. These fall into two classes, opiate or opioid derivatives and adsorbent agents. The opiate or opioid derivatives include loperamide and a combination of diphenoxylate and atropine, as well as tincture of opium. These agents act on smooth muscle in the GI tract to slow GI motility. So there is more reabsorption of fluid from the stool. Tincture of opium is not recommended unless patients are a severe resistant case and are not responding to other agents. These agents are not recommended in patients who have bacterial enterocolitis. In patients who have bacterial diarrhea, the toxin can be retained. This becomes even more concerning in patients who are not on antibiotics for their bacterial infection. The other agent in this group are the adsorbent agents. These are bismuth subsalicylate or adipolgite. These can bind bacteria or toxins within the GI tract. They do not slow the gut down. They simply bind the toxin. The next disease states that we'll discuss are GERD, or gastroesophageal reflux disease, and peptic ulcer disease. Non-pharmacologic interventions should be recommended. However, they should be used in conjunction with pharmacologic therapy. Patients can be counseled to avoid foods or medications that may exacerbate their GERD. They can avoid medications that may delay gastric emptying. They can reduce weight. They can elevate the head of their bed. They can eat smaller meals throughout the day and avoid eating 2 hours prior to sleeping. There are many other non-pharmacologic interventions that are recommended as well. Some have varying efficacy, so again, these should be used in combination with medication therapy. The American College of Gastroenterology produces guidelines for the treatment of GERD. They state that acid suppression is the mainstay of therapy. Antacids and over-the-counter acid suppressants are appropriate for initial self-management, and further workup should occur if there are persistent problems. The initial approach depends on the frequency and the severity of symptoms. There are 2 ways to approach the patient with GERD. First is the step-down treatment. In the step-down treatment, it's recommended that patients be started on maximal therapy first, so a therapeutic dose of a proton pump inhibitor. Proton pump inhibitors are always going to be appropriate as first-line therapy for patients with documented esophageal erosion. They will provide rapid symptom relief, and they may potentially, the downside of the step-down treatment is that it may potentially over-treat our patients, and it may be more costly. However, it will provide good symptom relief. With this approach, after that maximal treatment with a proton pump inhibitor, we can then de-escalate therapy as needed. The step-up approach is just what that sounds like. So patients would be recommended to start with a lower dose over-the-counter product. This may potentially undertreat the symptoms and may potentially lead to a prolonged time before the patient may experience relief. However, it will avoid overtreatment and potentially the initial cost of treatment may be lower. Antacids can be used in the management of GERD, and we'll not extensively cover these, but just want to briefly touch on a few things to think about. Antacids are appropriate for patients who experience symptoms less than twice per week, or they can also be used for breakthrough management. Per the AGA, the American Gastroenterological Association, the effectiveness of antacids is approximately 20%. They do have many drug interactions. Most of the agents in this class are divalent cations, such as aluminum, magnesium, or calcium, so they may chelate with many drug products. For example, these may include some antibiotics like tetracyclines or fluoroquinolones, and it is recommended that doses be separated and that these other agents be given an hour before or 2 hours after administration of the antacid. There also are some acid-labile drugs that do depend on an acidic environment for absorption. These include things like itraconazole or iron. When these are given in combination with antacids, we can have a reduced absorption. Just a couple of key medication-specific concepts. Aluminum is very constipating. Magnesium has the potential to cause diarrhea. Calcium is also very constipating. So that's one reason why some of our antacids have aluminum and magnesium used in combination, because the constipating effects of aluminum combined with the diarrhea effects of magnesium may cancel each other out. There also may be accumulation of both aluminum and magnesium in patients who have renal disease. So we want to make sure that we're recommending reduced doses or avoiding these agents in our renal failure patients altogether. The first group of medications that we'll discuss are the H2 receptor antagonists, or H2RAs. Drugs in this class include cimetidine, famotidine, nizatidine, or ranitidine. Some of these products are available over the counter. Typically, these are available at half strength. Some of them are available as prescription agents. These have reversible inhibition of the histamine receptor on the parietal cell. So these are stimulation at the H2 receptor does cause the release of acid. Over-the-counter H2 receptor blockers can be used for the self-treatment of intermittent symptoms. You should be helping to educate patients who are on these that they should also have an office visit or continued monitoring of their symptoms to determine if they need additional therapy. Patients can develop intolerance to these agents. Their onset of action is about 30 minutes and they have a duration up to about 10 hours. These are less effective than proton pump inhibitors in healing erosive esophagitis. They're good at decreasing both basal secretion of acid and nocturnal secretion of acid. They're not as good at decreasing acid associated with eating. To summarize mechanisms, antacids will help to neutralize pH. These decrease gastric acid secretion. Proton pump inhibitors are more effective than these agents because these agents do not block all acid secretion. H2 receptor antagonists are typically very well tolerated. These medications are selective for the H2 receptor, which are not located in many other areas, and therefore they have few adverse effects. These medications are renally eliminated, so they do need to be dose adjusted for a decrease in renal function. We also need to consider a dose adjustment in our older adults because of their decreased renal function due to age. The most common side effects are CNS related and include things such as headache, dizziness, and confusion. Adverse effects, again, are more common in patients who should have a dose decrease but don't, and in those who are older. There are also some drug interactions. Because these are lowering our pH, because these are raising our pH, they may affect medications which have pH-dependent absorption. Cimetidine is also a cytochrome P450 inhibitor, and it may compete for tubular secretion in the kidney with other medications. So there are a lot of drug-drug interactions with cimetidine. Because of this, cimetidine has fallen out of favor and is not frequently recommended as a first-line agent. The next class that we'll discuss are the proton pump inhibitors. This includes drugs such as dexlansoprazole, esomeprazole, lansoprazole, omeprazole, rabeprazole, and pantoprazole. These irreversibly inhibit the proton pump. This is the ultimate secretor of gastric acid. It is the final step in gastric acid secretion. Basically, these medications react with an enzyme that will interfere with the pump. With full effect, we can expect a 95% reduction in gastric acid. The H2 receptor antagonists take effect relatively quickly. However, these can take 5 to 7 days for full onset. An 8-week course is recommended for symptom relief. There is no efficacy difference between the different agents within this class. These agents are the most effective agents that we have for the short-term management of GERD and erosive disease. Their best effect is when they are taken before meals. If the medication is prescribed as BID, so twice daily dosing, it's recommended that patients take their first dose before breakfast and the second dose before supper, as opposed to bedtime. Ideally, they should be taken about 30 to 60 minutes before a meal. Some of the newer agents within this class may offer a little bit more flexibility with dose timing. These have a longer duration of action than compared with the H2 receptor antagonists. They are also a little bit more costly. However, they are relatively well tolerated. Most commonly reported adverse effects include headache and diarrhea. There also is some potential for B12 and magnesium deficiency with long-term use. There are some drug-drug interactions that can occur with this class of medications. There may be delayed absorption of ampicillin, digoxin, iron, and ketoconazole. These may have a delay in absorption because these agents need an acidic environment in order to be best absorbed. There are some other considerations to think about with these agents. A decrease in gastric pH can promote bacterial colonization of the stomach and respiratory tract. Short-term use may increase the risk for community-acquired pneumonia. However, this risk isn't seen with long-term use. These also may increase the risk for Clostridium difficile or C. diff associated diarrhea. These should be used cautiously in patients who are at increased risk for pneumonia or C. diff. They also may increase our risk for fracture. We should also use these agents cautiously or judiciously in patients who have other risk factors for hip fracture. They can continue to be used in patients who have known osteoporosis. There's also quite a bit of data, although it's weak and some of it controversial, that there may be an association between proton pump inhibitors and dementia, cardiovascular disease, and renal failure. We don't have solid answers related to these associations. However, I think it is prudent to point out that while these agents are very frequently prescribed, they do have side effects associated with them, some of them more serious in nature than others. So we should be using these agents judiciously to ensure that we're not putting our patients at increased risk. We can also consider a promotility agent as adjunctive therapy. One agent that can be used is called metoclopramide, or Reglan is the brand name. This can facilitate gastric emptying. It works as a cholinomimetic and a dopamine antagonist. It helps to improve GI motility by releasing acetylcholine from the myenteric plexus, which results in contraction of the smooth muscle. This medication is contraindicated in patients who have Parkinson's disease, seizure disorders, as it can lower the seizure threshold, and bowel obstruction. The dose does need to be adjusted in patients who have renal failure. Adverse effects include dizziness, fatigue, hyperprolactinemia, anticholinergic effects such as constipation, dry mouth, and sedation, and extrapyramidal effects. It is because of these extrapyramidal effects that the agent should be avoided in patients who have Parkinson's disease, as it can worsen their disease. Patients with peptic ulcer disease may have gastric or duodenal ulcers. Gastric ulcers can be caused by H. pylori, NSAIDs, and stress. These are typically characterized by epigastric pain, which is worse with eating, heartburn, bloating, and nausea. Duodenal ulcers are most commonly caused by H. pylori. However, NSAID use can be a potentiating factor as well. These typically present as epigastric pain, which is often relieved by eating, heartburn, bloating, and nausea. Because NSAID use can affect both gastric and duodenal ulcers, we should always be thinking about the potential for GI-related toxicity in patients who are using NSAIDs. Those who are considered to have high GI risk are those who have had a history of a previously complicated ulcer, especially if it is recent, or those who have 2 or more risk factors. Patients who are at moderate risk are those who have 1 to 2 risk factors. They are above the age of 65. They may be using high-dose NSAID therapy. They may have a history of an uncomplicated ulcer, however, it may not be as recent. And then patients who have drug interactions. So patients taking aspirin, including low-dose aspirin, 81 milligrams, corticosteroids, or anticoagulants. Those who are at low risk for developing an NSAID-associated ulcer have no risk factors. If a patient does develop an NSAID-induced ulcer, we should consider discontinuation of the NSAID. We should test for H. pylori and treat if it is positive. A proton pump inhibitor is a drug class of choice for both healing and secondary prevention. Misoprostol has a similar efficacy to proton pump inhibitors, but it's not used as frequently because it's poorly tolerated. The main side effect here is diarrhea. H2 receptor antagonists are inferior to both proton pump inhibitors and misoprostol in both the healing and prevention of NSAID-induced ulcers. For the treatment of H. pylori, a 7 to 14-day course is recommended to eradicate it. American College of Gastroenterology recommends a 14-day course. They say that's the preferred duration. There are multiple regimens that can be used. Some of these, they all include proton pump inhibitors. It also includes a variety of different antibiotics, amoxicillin plus clarithromycin, as well as a PPI. Metronidazole can be substituted if patients have a penicillin or a macrolide allergy. We can also consider quadruple therapy with bismuth subsalicylate, metronidazole, tetracycline, and a PPI. There are additional regimens included in your references. Next, we'll discuss the pharmacotherapy of irritable bowel syndrome. Irritable bowel syndrome, or IBS, occurs because of an altered gut reactivity. The gut is hypersensitive, and it has enhanced visceral perception and pain. There's also dysregulation of the brain-gut axis. This is possibly associated with a greater stress reactivity and altered modulation of visceral afferent signals. Pharmacotherapy is aimed at the nature and severity of symptoms. There is often a psychosocial component to this disease. If patients present with abdominal pain, we can consider an antispasmodic or a tricyclic antidepressant because of their anticholinergic properties. If patients have dominant constipation, we can think about increasing dietary fiber. And if patients present with diarrhea, we can consider using loperamide, an antidiarrheal, at a dose up to 16 milligrams total per day. Serotonin does play a role in regulating GI motility, sensitivity, and secretions. Because of this, there are some serotonin receptor agents which are available for the treatment of IBS. One of these is tegasterod. It's used for constipation dominant. It can result in enhanced motility throughout the GI tract. It was withdrawn from the market in 2007 due to an increase in cardiovascular side effects. However, it is still available from the manufacturer in emergency situations. They consider those to be those situations that are life-threatening or serious enough to require hospitalization. So it does have restricted access, but can be accessed if needed. Another serotonin agent which is more for the diarrhea symptoms, is alocetrone, or Lotrinix. This is a serotonin receptor antagonist. It was approved in early 2000, withdrawn from the market later that year due to concerns about serious and fatal GI side effects. It returned to the market in 2002 on a restricted basis. It should only be used for women who have diarrhea symptoms that are refractory to all other prescriptions. In 2016, some of the restrictions related to prescribing were lifted. Providers do need to complete training before prescribing it, but is not restricted to certain providers for prescribing. Lubiprostone is indicated for the treatment of chronic idiopathic constipation that's caused by IBS, and opioid-induced constipation in patients who have chronic non-cancer pain. It's available as an oral capsule and works as an osmotic laxative. It's a locally acting chloride channel inhibitor, which is going to increase intestinal motility and stool passage. Most common side effects with this agent, which occur in about 25% of patients, are GI in nature: flatulence, nausea, diarrhea, etc. Another similar product is linaclotide, or Linzess. It's approved for the treatment of chronic idiopathic constipation or constipation caused by IBS. It is a guanylate cyclase C agonist. Its actions are going to lead to an increase in intestinal fluid and accelerated transit. Also acting very similarly to our osmotic laxatives. Again, this is available as an oral capsule. Its most common side effects are GI in nature. About 20% of patients report diarrhea with this agent. Antidepressants can be used. Use is based on if the patients have an anxiety component associated with their IBS. They may have a centrally mediated or local effect on the gut as well that may change visceral and or motor activity. Tricyclic antidepressants and SSRIs seem to have a centrally modulated pain-reducing effect. So if these patients do have an anxiety component or concomitant depression, an antidepressant may be worth trying because of its effects on both the psychosocial aspect as well as the IBS symptoms. That concludes our coverage of lecture material for this topic.